My conflicts are listed here, and this should not touch this presentation. My talk will first summarize consented suggestions and recommendations on the diagnosis and care of acute kidney injury. Later, I will try to show data on how good we are at managing acute kidney injury on the general wards, before I try to answer the question whether quality of care and outcomes are potentially, if they are linked. I'm sure you will all be with me when I say we are striving for different things in life, but we will all strive for best possible care for our patients with acute kidney injury, and tubular biomarkers may be a part of this. However, today I want to make a completely different point, which refers to an improved use of our clinical routine parameters, which are available to us every day. Specifically, we need to pay much more attention to even mild increases in creatinine in all patients on general wards. And this is the time window I want to speak about today, which is when creatinine starts recognizably to rise or urine output starts to fall. And this is because even if relatively late in the course of renal function deterioration, creatinine and urine output still carry a very important signal, as demonstrated by prediction of in-hospital mortality at the time of AKI diagnosis. And stopping pathomechanisms very early in the course, or as early as possible, using creatinine increase or urine output decline will help the kidney to recover. And there are reasonable, although not all completely proven measures, as summarized by the KDIGO clinical practice guideline on the management of AKI, to deliver best possible care. This includes the determination of AKI grade and cause, and then according treatment measures. However, mortality is still high and unchanged, high in patients with acute kidney injury, as previously shown. And this is also true for hospital-acquired acute kidney injury and community-acquired acute kidney injury. Both deserve our attention. So what we are looking at is the greater than 50% creatinine increase within 7 days, or the greater than 0.3 milligrams per deciliter increase of creatinine in 2 days. For practical reasons, for a hospital-wide approach, creatinine increases offer some advantages over the less frequently measured urine output in this regard. And so putting these things together, in 2009 in England, the National Confidential Inquiry into Patient Outcome and Death report, the Support report, found in patients who actually died in hospital with AKI that only 50% of them had a good quality of care, and good practice was defined as a standard that you would accept from yourself, your trainees, and your institution. And most room for improvement was found at the individual clinical care for these patients. So patients were referred to renal only in 5% of cases. AKI risk factors before AKI occurred were rarely acknowledged. 40% of patients with AKI received no timely senior review, and 20% of death cases were considered as avoidable. Only 8% of patients with AKI had ambulatory follow-up. So there was much room of improvement, and the ENSIPOD concluded that treatment errors contribute to low quality of care, that all patients with AKIs should be seen early by a senior doctor, and that interdisciplinary treatment might be advisable. So, but what did the ENSIPOD report not measure? All the other patients with AKI who not died, where AKI was not coded and not detected, so there is much more to this. After having shown that what doctors do in patients with AKI or don't, just one slide from Nick Selby, who contributed, thankfully, that to me. A questionnaire to patients. What do they know actually? What their kidneys are doing and what they are important for. Only 50% were aware that their kidneys were making urine. So there's much work to do for recognition and of the importance of kidneys. And maybe that acute kidney injury in cases where it has been missed is not that important, but maybe this is not true. Unfortunately, it's not true, because Miran and colleagues showed in a nice work just recently that in patients with missed AKI, the mortality rate, a long-term mortality rate, was 33%, and 39% of these patients developed de novo chronic kidney disease or progressed from previously known chronic kidney disease to a higher stage. Underdiagnosis of AKI has been confirmed even years after the ENSIPOD report, shown in the same work as on the previous slide, with imaging, which is renal ultrasound, and bicarbonate states checked only in the minority of patients. There may also be an under-referral status to renal, given that only around 5 to 10% of patients middled over the stages were referred to nephrology. This may all be not so important if all patients with AKI were treated on a nephrology ward, but this is, of course, due to capacity limitations, not the case. In own data, we found that only 6% of patients with AKI in a hospital-wide approach were treated on our ward. So most of patients were treated outside of nephrology. AKI underdiagnosis and undertreatment may therefore well be a problem of single countries like the UK, as shown, and maybe somewhere else. There was a nice work in The Lancet, published by Yang and colleagues, which showed that the timely recognition of AKI was only found in 20% of cases, regardless whether these patients were treated in academic hospitals or local hospitals. And this study involved a questionnaire and a screening of about 2 million Chinese hospitalized patients spread all over the country. But these issues are also a problem, obviously, in the United States of America, as shown in an interventional study using AKI alert systems. But I wanted to use the study to demonstrate how usual care was in terms of applying contrast media and nephrotoxins in the setting of acute kidney injury, which actually did not change over time, and compared to the intervention group at all. So there may be as well a problem of delivery of care in the United States, at least in Philadelphia, given that it was only a single study. But Germany will be fine, won't it? At least there should be no data on this issue as usual, but we tried to tackle this and try to provide some data of this in 789 patients admitted to a university hospital in Germany, where we found an AKI incidence of 4%. of these hospitalized patients. Length of stay was double that of patients without AKI. Hospital mortality was set at 12%, and readmission within 30 days was at 14% of cases. And in a subset of patients, of these patients who presented with acute on chronic kidney disease, we found 65% of patients with drug failures and with renal complications, including hyperkalemia or lung edema. And time till nephrology consultation was 3 days on average in these cases where nephrology consultation was requested, which was in 15% of affected patients. The documentation and documented care of patients with AKI was rather poor, with rates of 30% in the records. So I think the UK took a leading role in tackling these issues. They had already a consensus conference on the meaning of electronic alerts for acute kidney injury on general wards. And they came to the conclusion 5 years ago that identification of AKI in both primary and secondary care should be facilitated through the introduction of e-alert systems. And that went so far that they introduced the patient safety alert in England as a directive for early AKI identification since March last year. This NHS England algorithm uses the KDIGO criteria, gives advice on the baseline creatinine value on an individual basis, is fully automated and in real time, and gives the information about AKI within the laboratory software. Because so many studies on electronic alert systems are out now, I tried to summarize these data in a systematic review where data are summarized from more than 28,000 patients with acute kidney injury, on average 71 years old. 50% of patients were female, in fact. Not all studies reported all outcomes. AKI incidence in hospital averaged at about 8.5%. AKI stages, 1, 55%, 2 and 3 taken together, nearly 50% of all cases had moderate to severe acute kidney injury. 10% of patients progressed from their initial AKI stage to a higher stage. 4% needed acute renal replacement therapy, and renal referral was requested in, again, about 10% of cases. Mortality, as previously shown outside electronic AKI alert systems, increased stepwise from high 17% at stage 1 to even much more higher, 36% in stage 3. So what were the characteristics of e-alert used in these 15 identified studies? 100% of studies reported to have used a creatinine increase. One study, in addition, used urine output. 93% of alerts operated hospital-wide and delivered the alert directly to the ward. 86% combined the e-alert AKI diagnosis with a comprehensive care bundle or with direct nephrology referral. 69% were automated and 64% operated on a non-interruptive basis, which means that the physicians on the ward could continue their routine works until they recognized that AKI diagnosis was shown in the pathology program. Out of these 15 studies, 10 were on a controlled basis, and out of these 10, 6 delivered process-relevant endpoints, and out of these 6, 5 reported improved adjustment to drugs, improved senior physician referral within 24 hours, and improved proportion of patients having actually had a renal ultrasound. And one of those report optimized fluid status and hemodynamics. For patient-relevant endpoints, I just show hospital mortality with 3 out of 6 studies reporting lower mortality in the intervention group, and the slide only summarizes studies where the AKI alert was linked actually with a comprehensive care bundle, not only with the pure referral to the 250 pages long KDIGO practice guideline, or even linked with a nephrology referral. So in none of these studies, survival was worse in the intervention group compared to the control group. So having funding together for a pilot trial, we are combining AKI alert with a nephrology referral approach, applying a care bundle, as has been demonstrated and nicely published several times by Kohle and Nick Selby, where the use of a care bundle resulted in reduced early mortality, which also translated into reduced long-term mortality, which made the authors conclude that the use of a simple care bundle, which referred to the usual ABCD of care for acute kidney injury, was associated with reduced progression of AKI to higher stages and decrease in hospital mortality. Implementation of an AKI care bundle may assist in improving outcomes in all healthcare settings and should be considered as part of the International Society of Nephrology's campaign to eliminate all avoidable deaths from AKI by 2025. AKI alerts do not address by itself the heterogeneity of AKI, but still even allow earlier recognition of rarely and specifically treatable causes of AKI, such as vasculitis. Just a brief view on the perspective before I come to conclusion. A research agenda on AKI alerts has been provided by the Acute Dialysis Quality Initiative and just published in a series of papers. I'm sure you're aware of that. Baseline creatinine should be, there should be a link between ambulatory and hospital creatinine values, which is not the case so far in Germany, not at all. The development and validation of an acute care bundle should be continued. AKI alerts should be linked to AKI registries and outcome databases. For further approval of in-hospital, the in-hospital ambulatory information exchange, intersectoral exchange by physician's letter or patient kidney care card should be acknowledged with several ideas into the one and the other direction. So I would like to summarize: ensuring the quality of AKI care remains an international issue. The early individualized unspecific kidney treatments still remain a priority until specific treatments are available even on the general wards, not only in the ICU. E-alerts, care bundles, and further elements of care may shorten the time to effective treatment and contribute to better outcomes. Thank you for attention.